So, hello everyone, good afternoon. I want to welcome you all to today's lecture within this year's Robert Koch Colloquium. And before I hand over to Dr. Wieler, President of the Robert Koch Institute, for some welcoming words, one additional information. For the ones who are following the lecture via WebEx, you can ask your questions at the end of the session in the chat. Please address your questions to the host and the moderator. If you're watching our live stream on YouTube, please send us your questions on the email address rkc@rki.de, and you will find it also in the info box below the video stream. That's all from my side, and I hand over to Dr. Wieler. Thank you.
Yes, hello everybody. In particular, greetings to Justine Fitzpatrick. We are more than happy to have you here. And as you may know, you're already the second speaker from Public Health England. That gives us the pleasure to introduce a topic that is of utmost importance for every single public health institute in the world. So basically, of course, also for the Robert Koch Institute. This is the third lecture of this year, Robert Koch Colloquium on Public Health Surveillance. The second talk regretfully had to be skipped, cancelled, and we hope we can have this talk later, but I'm not sure whether this will be possible. We're trying for the best. In the previous lecture, though, we looked into specific topics of public health surveillance, including the surveillance of mental health and the molecular surveillance of infectious diseases. However, today, and this is why I'm particularly fond to listen to you, Justine, today, we will hear about an overarching public health surveillance system developed at Public Health England with relevance for the prevention and control of non-communicable as well as of infectious diseases. And I'm really happy that you will give us an insight into this topic today, because you have obviously an really outstanding expertise in this field. So I'd like to briefly introduce you, Justine. She's head of Population Health Analysis in the Health Improvement Directorate at Public Health England. She graduated from London School of Hygiene and Tropical Medicine with a Master of Science in Medical Demography. Before joining PHE, Public Health England, she was Deputy Director at the London Health Observatory. She also worked at the Office for National Statistics on the topics of health inequality. And I think during this pandemic, the Office of National Statistics has become very, very well known to most of the German citizens. Within Public Health England, she's responsible for the Public Health Outcomes Framework, an indicator-based surveillance system which serves to monitor the improvement of the population's health and the reduction of health inequalities in England at the national as well as the regional and sub-regional level. At the heart of the process is the thorough selection and definition of indicators that are aligned to the government's strategy for health improvement. These indicators include life expectancy, healthy life expectancy, and various other indicators relating to the occurrence of disease, determinants of health, and health service use. Applying a refined system of data collection, Justine and her team analyze time trends and spatial distributions in population health. Data are continuously collected and results are visualized along the grid of public health domains and indicate indicators in the so-called fingertips platform in order to inform public health authorities and other stakeholders and to provide advice with regard to public health action needs. And obviously, this is something that the Robert Koch Institute would love to have in the future. She has been involved in advising the development of the diabetes surveillance, therefore, at the Robert Koch Institute. She contributed to the International Work Group on National Public Health System responses to diabetes and other non-communicable diseases, which actually took place at the Robert Koch Institute in June 2018. The COVID-19 pandemic has illustrated to all of us that there is a close interrelationship between infectious and non-communicable diseases, and that we need to join efforts in developing innovative methods for the continuous and timely collection an analysis of public health data, the visualization and dissemination of results, and surveillance-based modeling of health trends in order to secure and improve the health of the population, from data to action. This is the motto that we all thrive for in the public health world. So therefore, again, I just have to mention again that we are all very grateful that Justine Fitzpatrick, that you share your insights into the development of public health surveillance system with us today. And we're looking very much forward to your lecture entitled Public Health England's Approach to Non-Communicable Disease Surveillance and Monitoring. Please, Justine, the floor is yours.
Thank you very much. So let me just share my screen. Hopefully you can see that now. So thank you very much for the introduction. So yes, I'm Justine Fitzpatrick and I'm currently Head of Population Health Analysis within the Health Improvement Directorate within PHE. So I take a lead role in the surveillance of non-communicable diseases. I've also very recently taken over a temporary role as co-director of health intelligence. So I now have broader oversight, essentially, of the analysis and dissemination of data and evidence to inform health improvement activities. So this is an overview of what I'm going to talk about today. So first of all, I'll give you an introduction to Public Health England and introduce our division, our Health Improvement Directorate and our Health Intelligence Division. I'll introduce Public Health England's approach to non-communicable disease surveillance. I'll then talk through the example of the Public Health Outcomes Framework, what that is and how we use that. I'll then move on to talk about the impact of the COVID-19 pandemic and how it's changed the demands really for our work over the last year. And finally, I'll talk a little bit about where we hope to go next, really, with all of this. So I'll start with an introduction to PHE. So Public Health England is an agency of the Department of Health and Social Care in England, and that means that we are a distinct organisation from the Department of Health, we have operational autonomy, essentially. And we define our role as outlined on this slide, so to protect and improve the nation's health and well-being and reduce health inequalities. And we do this through world-class science, advocacy, partnerships, knowledge and intelligence, which is where I work, and the delivery of specialist public health services. We have a high-level 5-year strategy that outlines the key priority areas for us in terms of work. And we also have an annual business plan and an annual remit letter from the Department of Health and Social Care that outlines the plans for delivery, essentially, for the year ahead. So briefly to talk about PHEs role in non-communicable disease surveillance itself. So surveillance generally is a core function of Public Health England, and we have a document that I've listed here, Public Health England's approach to surveillance, that sets out our overarching role in the surveillance of both communicable and non-communicable diseases, and also the principles for surveillance within PHE. And essentially the goal is to provide information that can be used to inform action, to improve health, and importantly, to reduce health inequalities. And that kind of, those principles ensure that PHE and others have the right information available at the time that it's needed to inform action and decision making. But I think it's important to stress that we don't do any of this on our own, and we do it in partnership with academic institutions and also with other public sector bodies and internationally now as well. So none of it can be done in isolation. We have to work in partnership with others in order to achieve our goals. Ooh. Oops. Sorry about that. Sorry about that. So hopefully you can see this slide now. So this is a kind of overview of PHE's strategy for the next 5 years. You can see that on here we have 10 priority areas for action. So these are the 10 areas that PHE has decided to focus on for the next 5 years, both to protect people and also to enable people to live longer, healthier lives. Now, these 10 areas don't cover everything that PHE does, obviously, but what they are the 10 areas where we believe we could have an impact, or the biggest impact, in the coming 5 years. So it contains many things that you might expect to see in a strategy for a public health agency. So, for example, aiming towards a smoke-free society, promoting better mental health, etc., and effective responses to major incidents. But you can also see that priority 9 is enhanced data and surveillance capability. So it was set out as a key priority for PHE for the next 5 years. Some of the work we were planning in that area was paused or adapted through the pandemic, but other aspects have been accelerated, and I'll say a bit more about some of that later on. I'm primarily going to focus on non-communicable disease surveillance. So I'm not going to talk specifically about what PHE has done in terms of its pandemic response specifically. This is the structure of the Health Improvement Directorate within PHE. So the first group you have in the middle, the first few lines relate to all the divisions within the Health Improvement Directorate. So I'm in the Health Intelligence division, and within that I lead the population health analysis team. But you can see we have other teams covering other aspects of health intelligence. So there's the public health data science team, which I work very closely with, the clinical epidemiology team, who work very much more on things that are health service related and NHS facing work, really, more clinical work, I should say. And you've also got the local knowledge and intelligence service, and that team primarily is working with our local areas and regions. The life course team, who are focusing primarily on developing a life course approach to health intelligence and health improvement. And then we have a training and workforce development team. So I lead on NCD surveillance for the directorate, working closely with these other teams and also working closely with those who do infectious disease surveillance in the National Infection Service. So this slide sets out the role of the population health analysis team that I lead. So as I've said, we lead the analysis and monitoring of non-communicable diseases. We also analyse risk factors such as smoking, alcohol, etc. And we do the monitoring of our food reformulation programmes. So those are programmes that are aiming to reduce, for example, the sugar content of food that's sold, etc. And we also look at the wider determinants of health. And as part of that, we produce a number of PHE's high-profile products on the health of the population. So the Public Health Outcomes Framework, which I will talk about, the Health Profile for England is a role for my team, and also the local health profiles. And those profiles are kind of products that look at the health of very small areas within England. We also take a lead role in the analysis of health inequalities, and particularly we've done quite a lot of developmental work on how to measure inequalities and how to monitor change in inequalities over time. And we do a lot of that work with our academic colleagues. And we also have a role in responding to what I've called here hot topics. Those are kind of emerging priorities that may not have existed previously. So obviously one example of that is the impact of the COVID-19 pandemic. And I will say about some of the things we've done on that. And we've also done quite a lot of work on trends in mortality. So even prior to the COVID-19 pandemic, there had been a slowdown in improvement in life expectancy in England and in many other European countries, but it was particularly apparent in England and the rest of the UK. So we did a lot of work prior to the pandemic on what the potential reasons for that were. And we do all this obviously to inform national and local decision making. So we try and translate complex data and analysis into simple messages. And we do a lot of work with our users to help them to understand our products. And a lot of that is done through our local intelligence service that I mentioned earlier. And we also work with users to try and assess their needs and fill any intelligence gaps that they might have. So now I'll move on to talk specifically about non-communicable disease surveillance. So this is the definition of surveillance that we use in PHE. So surveillance encompasses everything from public health data collection, analysis, interpretation, and dissemination of that information. And as I said earlier, although all of these parts of surveillance, or all of these parts of the surveillance system are essential, we don't do those things on our own. We do them in partnership with others. And some of the things or the principles that we follow for surveillance is that it needs to be undertaken on an ongoing basis. The aim is obviously to provide indicators of population or group health status or the determinants of health. The aim is that those indicators are comparable over time or between areas and that incorporate levels or triggers for action where possible. That's sometimes a bit of an issue in health improvement or in non-communicable diseases where there are many overarching indicators such as life expectancy, where the possible actions to improve such an indicator would be very varied and the responsibility of many different organisations and teams. But nevertheless, that is a kind of aim of the system. So yeah, the aim is that there is a link to an explicit set of actions with timeframes and accountabilities for taking forward those actions. And as I said, this is all part of a system. And so the aim is that each part of the system is covered and undertaken by somebody. So this slide sets out the general model that we work to in Public Health England. And it was initially developed, I think, for a review of health surveillance in Canada. I'm not going to go into all the details of this model, but what it does show very clearly is all the interconnected elements of the system. So if we just look at the three blue circles on the left-hand side, they're the three essential parts of the system, really, and they are driving forward the outputs from surveillance. So first of all, you've got the data collectors, then the surveillance experts, and then the sponsors. So the data collectors' role is to ensure that comparable data are collected and available for the surveillance experts to use. The surveillance experts, which is essentially the box that my team would fit into, are there to ensure that the data are analysed appropriately, that they're interpreted and translated into recommendations or into conclusions that can be acted upon by those responsible for initiating action or improving service delivery. And then the third element is the sponsor, and the sponsor's role is really to set the objectives and priorities for surveillance, but also to make policy decisions about action to be taken on the results of the surveillance, essentially. And as I alluded to earlier, really, the sponsors, there are a whole range of sponsors for non-communicable diseases. And the Public Health Outcomes Framework, which I'll talk about in a minute, has many indicators within it. I've lost count, actually. I think it's 60 or 70 indicators. And each indicator has a policy lead. So in effect, each indicator has a sponsor. And their role is to initiate and ensure action around that indicator. And the other thing you can see on this slide in the blue box on the right hand side is the whole range of users that there might be for the indicators that we produce as part of surveillance. So there's policymakers and those involved in other forms of response and those involved in research. So I'm going to move on now to talk about those three circles that I talked about, and so the three main kind of parts of the surveillance system, if you like. So the first one is data collection. So PHE is not primarily a data collection organisation on the non-communicable disease side. We do more data collection on the communicable disease or infectious disease side, but often what we do in non-communicable diseases is use data that's been collated by others. However, we are responsible for a limited number of non-communicable disease data collections, such as the two that I've listed on this slide. So one is the National Cancer Registration and Analysis Service, and the other is the National Congenital Anomaly and Rare Disease Registration Service. So what we do primarily is fund organisations to collect data for surveillance purposes. So, for example, we fund a lot of questions in surveys, in national surveys run by other organisations, often the Office for National Statistics or other organisations. So we fund particular questions, mostly about risk factor surveillance in those surveys, things like smoking prevalence, etc. And we've had to adapt this quite a bit throughout the pandemic to enable us to have more frequent information on some of these things. So, for example, we've asked more regular questions about mental health and loneliness, for example. And we also collate data that have been collected by other organisations. And I've listed some examples on this slide. The main data sources that we use would be death registrations, hospital episode statistics, that's information on people who've been admitted to hospital. We use data from other government departments, particularly if it's about the wider determinants of health. We use data from public health programs, so specific programs that have been initiated to improve the health of the population, such as we have a health check program for people between, I think it's 40 and 70 in England. And we use national survey data, such as the Health Survey for England. And all of these data are stored in what we call our data lake. This is our central analytical data holdings. It says here for NCD surveillance, but it's actually much broader than that now, and it covers a lot of infectious diseases as well. And the data held in the data lake can be used for PHE for the purposes we've agreed in our data sharing agreements with the organisations who own the data. So, for example, I said we use death registrations. They're owned by the Office for National Statistics, and we have a data sharing agreement with the office, which sets out what we can and can't do with that data. And the data is obviously protected by appropriate information governance, controlled and administered by a single application process. And by that, I mean that they're available for use across PHE through an application. It's a web-based application service, and there are various criteria and things that have to be met for access to be granted. But that's how it's managed. The data remain in their original format, and this essentially facilitates ease of access and is an effective data management system. And if we have everyone across PHE using the same data, you know, the hope is that that leads to improved consistency of PHE outputs, etc. So we're not having people across the organisation using different versions of the same data. So the next blue circle on the diagram was around surveillance experts, which is essentially analysis of the data. And this is what most of my team are engaged in doing. So we essentially take the data and turn it into indicators of health outcomes, or behavioural risk factors, or indicators on the wider determinants, or indicators on health service use. And as standard, really, we produce all our indicators for different geographies. So they're obviously produced for England as a whole. We may also produce data for English regions, for local authorities, of which there are 152 in England, and for general practices. And the aim also is to produce data for different subgroups of the population. So, for example, by ethnic group or by deprivation group. And there has been an increased demand in that information during the pandemic. This analysis is undertaken regularly, usually annually, although again, during the pandemic, we've started to do a lot of things more frequently. Confidence intervals are provided, obviously to give an indication of the degree of uncertainty around a particular indicator, but also for benchmarking purposes, so that we can look at each area, individual area, or someone in an area can look at their own area and see how they differ from England or a regional value, for example, to see if they're better or worse than England as a whole. And we have an indicator methodological review group who meets regularly to ensure that all the indicators that we produce are produced to agreed principles and standards. So the indicator governance process is essentially our indicator assurance process. And the process was designed really to ensure that all our indicators meet the highest standards possible, and that those standards are consistent across the organisation. And also that there is transparency of the methods that we're using. So the idea is that we would make all our methods available in metadata for our indicators, so that if somebody else wants to take those methods, they should be able to reproduce the same indicator given the same data. And the principles that we work on are that all indicators should have a clear purpose and align with the organisation's core purpose, have a stakeholder sponsor, so meet a known need of stakeholders, use the most appropriate method, be transparent and clear, we aim for no duplication of effort within PHE or with partners. So we don't want one part of the organisation producing a slightly different indicator from another. And we make them all available in a central place, which we call the PHE Folio database. And I'll say a bit more about that later as well. And the Indicator Methodological Review Group meets very regularly to critically appraise the methods for any new indicators and also any changes to existing methods, advise on areas of improvement, suggest areas where people might be able to get help or advice on things that they are trying to do. And we also recommend a quality marking, and this doesn't happen that often. Essentially, all of the indicators that pass the methodological review are deemed to be of sufficient quality, but occasionally indicators might pass if they're methodologically sound, so there's a good method, but the data is not of particularly good quality, or it's a new data collection, or it's developing, in which case we would probably still recommend publishing that indicator, but we might mark it to say that the data quality is being improved. And this is really our process for producing indicators, the centralized indicator automation process. This is something that we've been developing over the last year, because the aim is to obviously increase the automation of the indicators that we produce. And this process is being established. It's up and running in many aspects, but not all aspects yet, I don't think. So the aim is that all our indicators would be produced using reproducible analytical pipelines. And what would happen is, as you see in the boxes on the left-hand side, you would feed in indicator definitions, and that means that you would define your indicator in terms of numerator, denominator, sources, methods, etc., and the data sources you need to calculate that indicator. And then the indicator automation is the R package. So in the statistical package R, it's all done in that, brings the whole process together, reads in the definitions and the data sources, and feeds out the finished indicator at the end, if you like. And while doing that, it calls on all the modular R packages listed in the blue boxes on this slide. So that's essentially what we have been trying to establish over the last year or so. And most of this, most of the code for this is available, and I believe the PHE indicator methods is a package, an open package as well, that people could use. Obviously, they can't use the data underpinning the indicators, though. And we present all these indicators once we've produced them in our web tool called Fingertips, which is our primary indicator presentation platform, and our system for visualizing and accessing public health indicators. It's publicly available, so anyone can go onto the site and access these indicators. There are 4 components to the system. So there's the data store, Folio, and really that's the indicator data store, which is different from the data lake where the raw data are held. Folio is where all the produced indicators are stored. There's a management system, which is for users within PHE to upload the data to Folio, essentially. And there's a user interface, which is the public website that people see. And there is an API, an application program interface, where people can download all the data in fingertips. And these are supported by specific R tools, and also, again, all the data is open source, all the code is open source, sorry, and all the data is available under the Open Government License. And within fingertips, which I'm going to show you in a minute, the indicators are organized into profiles. So the public health outcomes framework is an overarching profile, but we also have separate profiles for specific diseases. So there's one for cardiovascular diseases. We have them for risk factors. So there's one for, there's our local tobacco control profiles, there are local alcohol profiles. So there are quite a lot of profiles we've built up. Some only have a few users, a few interested users, and some have many. So the more broad overarching profiles have more users, obviously. It's freely available for anyone to access. Contains a range of indicators at national level and local authority level primarily. And it's intended for use by national organisations, local authorities, community groups and health services. And just a bit more about the audience. So most of our outputs and profiles have local authorities as the key audience. So local authorities are the organisations with responsibility for public health in England. And most of our users within local authorities are public health analysts and other analysts in the health system or in the broader local authority system. We do get some other users, politicians and other parts of local authorities using them, but primarily it's an analytical audience. We get internal users from PHE, so PHE health improvement teams would use them, use the profiles. The National Department of Health would use it, the National Health Service, other government departments and ministers. And we have some informed citizens and media using the profiles, but it's quite small really. And as I said, they're not the primary intended audience. So I'll now move on to talk about the public health outcomes framework. So the public health outcomes framework is the strategic vision, it says here, but essentially it's the framework for public health in England. And it concentrates, the aim of the framework or the vision is to improve two high-level outcomes. The first being healthy life expectancy, and the second to reduce differences in life expectancy and healthy life expectancy between communities. So essentially it's to improve health and the quality of life, not just the length of life, and reduce inequalities between areas. So those are the high-level outcomes or main indicators included within the framework, but underneath that there's a broad framework of public health indicators covering the whole of public health. So it covers health improvement and also health protection. The indicators are monitored at national and local authority level, and the aim is to help us understand how well the nation's health is being improved and protected, and to understand inequalities in England. And the FOF is published as guidance that local authorities must have regard to. It's not a performance management framework. It's guidance. So local authorities should be looking at these indicators and aiming to produce improvements in outcomes against these indicators. So this is a bit more detail on the FOF. So you've got the two high-level outcome measures at the top, increasing healthy life expectancy, and the second one to reduce differences in life expectancy and healthy life expectancy between communities. And then underneath that, there are 4 domains, and there are several indicators under each domain in the PHE. So the first domain is improving the wider determinants of health. And in that domain, we have indicators on things like employment, housing, education, giving children the best start in life. Those sorts of indicators are all in domain 1. In domain 2 is health improvement, and indicators in there focus around risk factor surveillance. So there's indicators on smoking prevalence, the prevalence of alcohol consumption, the prevalence of obesity, those sorts of indicators. In the health protection domain, we have indicators on things like immunization coverage, the incidence of some infectious diseases, such as sexually transmitted infections, for example. We also have air quality in the health protection domain. And then in domain 4, most of the indicators in domain 4 cover premature mortality from different causes. But there's a few healthcare related indicators in there as well. So indicators on hospital admissions for things like hip fractures, for example, are in that domain as well. And part of the reason for having all of these indicators and these domains is that although increasing healthy life expectancy and reducing inequalities are the overarching goals, those measures they may take a long time to change. So any action to address anything about those indicators may take decades to change. So the idea is that some of the indicators in the other domains have a kind of shorter time scale where you can see action. And also the aim is to cover all aspects of the life course. So there'll be indicators on children right through to older people. So this is what the Fingertips homepage looks like. And you can see there are many profiles here. There's one on child and maternal health, one on mental health, for example, one on cardiovascular diseases. So covering all aspects of health. There are some on communicable diseases, not so many. I'm looking for one now, can't see it. There's one on sexual health, reproductive and sexual health somewhere. Anyway, so, oh, there's a health protection one. So obviously the focus is primarily on non-communicable disease, but there are some others in there as well. So I'm going to primarily talk about the public health outcomes framework today, highlighted in red. So this is what we call the overview page. And this is, we recognize this is getting quite busy now. We've done a lot of developments on Fingertips over the years. And I think one of our next steps is to have a look at you know, how user-friendly it is, and maybe do a bit of work on the user journey. But what you have here is the overview page. So here I've selected the overview. Here I've selected local authorities in the London region. And I've selected the overarching indicators, which is healthy life expectancy and inequalities in healthy life expectancy. So what you can see here is, if I just take life expectancy at birth in males, which is here. So these are all across here, you have all the local authorities within London. And this is male life expectancy. And these are all the values for male life expectancy in London in that particular year. And an area is coloured red if it has significantly worse life expectancy than England as a whole. It's coloured green if it has better life expectancy than England as a whole, and it's amber if it's similar. So we look here at the local authority of Barking and Dagenham, and it's red for male life expectancy at birth. So it has worse life expectancy at the moment than England. And in fact, it's red on all of these. It's red on life expectancy and healthy life expectancy. It's red on all of these indicators. So this immediately enables you to compare Barking and Dagenham, that local authority, with other areas in London, but also to look at Barking and Dagenham and see how it compares across indicators. So this is the trend chart in fingertips. So I've selected trend here. It's the Barking and Dagenham local authority, and again, it's overarching indicators. And the indicator I'm looking at here again is life expectancy at birth, males. So what you have here is the trend in life expectancy in Barking and Dagenham compared to England. So the black dots are the England life expectancy, and the red dots are the Barking and Dagenham life expectancy. So the fact that it's red means that it's significantly lower, worse than England as a whole. But the trend is pretty consistent with England over time. It has increased, as has England's life expectancy. But unfortunately, it has stayed red throughout this time period. And what the tool also allows us to do is look at inequalities within Barking and Dagenham. So now I've selected the inequalities view. I'm still on Barking and Dagenham, the local authority in London, and I'm still on overarching indicators. And I'm still on life expectancy at birth, male. So what this is life expectancy by deprivation. So what we do here is we divide the small areas within Barking and Dagenham. Well, we take the small areas and look at the level of deprivation and then group them into 10 groups according to the level of deprivation. So the most deprived areas. So the deprivation we look at here is deprivation across a whole range of factors to do with a whole range of socioeconomic characteristics of the area. And it's kind of pulled together to create an index of deprivation. And then we organize the areas into deciles according to their index of deprivation. So the most deprived areas of Barking and Dagenham have lower life expectancy than the least deprived areas. And not only that, they also have lower life expectancy. These 4 most deprived deciles have lower life expectancy than England. That's why they're coloured red. And these sorts of presentations are available for nearly all indicators in the framework. Some, it's not possible to break down to these small areas. So we wouldn't be able to do this sort of analysis for every indicator. Life expectancy, we have lots of data, and it's quite easy to do these sorts of comparisons. So as I said in fingertips, the indicators are organized into profiles, and profiles can be used to identify when a national or local trend is getting worse, to identify where a local area has a worse level than national, and to identify inequalities. And alongside of that, we also produce statistical summaries on our key findings. We use the FOF to prepare briefings for ministers on particular aspects of health improvement. And we work with our local knowledge and intelligence service, as I've said before, to disseminate to local decision makers. So they will go out and talk to the local decision makers about the trends in health in their area. And they're called knowledge transfer facilitators, essentially. And so they work with the decision makers to undertake place-based surveillance and initiate action in the area. So I'm going to move on now and talk about how we've adapted to the with the COVID-19 pandemic. And essentially, we saw increased demand for information on the health of the population this year to cover both the direct and indirect impacts of the pandemic. So we had demand for new data collections, as I've already said, so more timely data on specific topics, new indicators that we hadn't looked at before, information at more small area level, and more inequality breakdown. So there were a lot of demands on our time, as I'm sure is the case in other countries as well. Again, I'm not going to talk about the work we've done for the direct management of the pandemic incidents. I'm more talking about the broader impacts of the pandemic. So we've developed 3 new tools this year. 2 are on this slide. So the first is the wider impacts of COVID-19 on health monitoring tools. I'm going to talk about that in a minute. We've also developed the COVID-19 Health Inequalities Monitoring Tool for England, and I'll talk about that now. And then after that, I'll just mention our 3rd tool, which is weekly excess mortality in England. It's not on this page because it's produced in a different software, but it's about to appear on this page. So if I'll start with CHIME, although CHIME does look at the direct impacts of the pandemic, and it is produced in reasonably real time, so it's more frequent than annually, as we would normally do, its real purpose is really to look at the long-term impact of the pandemic on inequalities, and also to inform recovery from the pandemic. So currently, the tool only includes information on COVID-19 mortality and COVID-19 hospital admissions, but there are plans to expand it to look at infections and vaccinations, essentially. So at the moment, you can look at mortality and hospital admissions, and you can look at inequalities by ethnicity, deprivation, region, age, sex, and also within regions, you can look by ethnicity and deprivation. So the link to the tools at the top of this slide, and here we've got cumulative age standardized mortality rates for COVID-19 by ethnic group. So it's cumulative from March 2020 to March 2021. And you can see how the inequalities have developed throughout the pandemic, really. But at the end of March 2021, the cumulative mortality rate in the Asian and Black groups was double the white group. So we have seen a much greater impact of the pandemic on Black and Asian groups in England. And this was apparent. There was a slight change in inequalities between the wave 1 and wave 2 of the pandemic, but essentially those inequalities have really persisted throughout the pandemic. And this shows the same information. So it's cumulative age standardized mortality rates, but this time by deprivation decile. So it's the same deprivation deciles that I was talking about earlier. And here, cumulative mortality at the end of March 2020 in the most deprived group was 2.4 times higher than the least deprived group. So those are the sorts of things that we've been doing in CHIME. If I move on now to the wider impact. So early on in the pandemic, it became apparent that the kind of impact on health was much broader than the direct impacts we were seeing on infection rates, for example. And this framework was published in the British Medical Journal in April 2021. And it looks at the pathway and the mechanisms by which the pandemic and the response to pandemic has kind of impacted various groups. and the various ways that these things may influence health. So, for example, at the top, on the second box from the left, you've got home isolation. And this, may lead to stress and boredom or unemployment, for example, further down the framework. And those things may lead to reduced physical activity or substance misuse or loss of income and so on. So I'm not going to go into the details of this diagram, but essentially it just sets out the complexities that we're dealing with and how everything is interrelated. And also how it may, the consequences of the pandemic may impact some groups more than others. So with this in mind, we established this tool, which looks very much like the CHIME tool, but it's the wider impact of COVID-19 on health tool. And the link is available on the slide. And this looks at a broad factors related to health that have changed throughout the pandemic. So we've got things like grocery purchasing, social determinants of health, mental health, etc., behavioural risk factors. So they're all presented in this tool. So this is grocery purchasing. I'm not sure whether this is something you've also seen, but this shows the number of grocery purchasing trips per household since January 2019. And you can see that essentially the number of trips was fairly stable throughout 2019. There was a bit of a blip around Christmas time. But then as you move into 2020, you can see that, well, the number of grocery purchases rose quite sharply before our first lockdown, and so did the number of trips. But after that, there was a drop in the number of trips made per household for grocery shopping, and they've stayed stayed below 2019 levels really since then. They've fluctuated a little bit, and this really, we think reflects the more permanent changes to people's shopping habits, potentially, since the start of the pandemic. So that's one of the things that we've been looking at. This shows alcohol-specific mortality. So it's age standardized, actually, alcohol-specific mortality by month. So the red line is 2020 and the green line is 2019 and 18. So it's 18 and 19 combined, well, the average of those two. So you can see essentially that since March, from March onwards, we've had a higher mortality rate for alcohol-specific conditions than previously. And I think this has been apparent for both sexes, for males and females. And also, this was also seen for alcoholic liver disease as well, which accounts for most of alcohol-specific mortality. And this is life expectancy. So we also looked at life expectancy for 2 6-month periods, so January to June on the left-hand side and July to December on the right-hand side. So this is, so what you see on the left-hand side is January to June 2015, up until January to June 2020. So you can clearly see the dip in 2020 for both 6 months periods, really. I think the other thing that we've seen though, and it's not really very apparent from this slide necessarily, is that the deprived group, so sorry, I should say this is by deprivation decile again. So the red line here at the bottom is the most deprived. And that really seems to have, the most deprived really seems to have had a bigger drop in life expectancy than the least deprived. And so the gap between the most and least deprived has widened in 2020. So essentially, indicating that there has been quite a substantial impact on inequalities of the pandemic. And then very quickly, I'll just talk about excess mortality. So the other thing that we've done is introduce weekly excess mortality reports in England. And they look like this. These are produced in Power BI. I think it's the scripts behind it run in R, but the presentation tool is Power BI, and we update this on a weekly basis. So what you have at the top is the number of excess deaths by week since March 2020. So excess mortality is the number of deaths over what we would expect for that week. And the expected is based on the previous 5 years, or the trend over the previous 5 years, so from 2015 to 2019. So you can see we've had two peaks really, or two waves of excess mortality, the first in spring 2020 and the second in the early part of 2021. And then at the bottom chart, you see the weekly registered deaths. So the orange bar is COVID-19, or deaths with COVID-19 mentioned on the death certificate. And the grey bars are those where it's not mentioned on the death certificate. We've also been able to break this down by various population subgroups. So this is not weekly excess mortality, this is cumulative excess mortality since March 2020. So this graph here, the top left one, is the number of excess deaths over that period by ethnic group. And obviously the white group is the largest group. That's why it has the largest number of excess deaths. However, when you look at the ratio of registered to expected deaths, you can see that comparatively speaking, we've had higher excess mortality in Asian and Black groups, which is consistent with what we saw on COVID-19 mortality. And here we have the registered deaths, the orange being COVID-19 and grey being other causes. And the table on the right just summarises some of that information. And this is the same information, but by region of England. If I just look here at registered deaths to expected deaths, you can see London really has had the highest excess mortality within England, closely followed by the West Midlands. So the impact has not been, has impacted some areas more than others. So just very quickly, we've had to adapt this year, as everyone has. So not only just by working at home more often than we might have otherwise done, but we've had to build resilience into the team in case of unexpected absences. And we've done that primarily by ensuring we have backup and things, but also increased automation of production so we can update things more regularly and easily. And we've done that by building reproducible analytical pipelines, essentially. So all of these three products that we've developed this year are produced in this way. So they use open source software where possible. So there are no barriers to updating from a software perspective. We make sure we've got proper version control and package management. We use functional programming, which means that we've got shortened functions and they're reused throughout the project, so it makes it simpler and more accessible for other people. And then of course we've made sure that we document and test everything appropriately, and all of the software, all of the code where possible is available for others to use. So finally then, what next? So where will we be going next? So several factors will influence where we go next. So the kind of continuing COVID-19 pandemic and its influence on the health of the population. We're also about to go through some organisational change. So PHE will cease to exist in October this year, and its functions are being transferred to other organisations. We're continuing to focus on new priorities. So we're continuing to look for alternative ways of capturing more detailed, timely data. We've done a lot of data linkage this year to enable us to reduce a lot of the analysis we have done, and we're looking at opportunities to continue doing that. We'll obviously continue to increase automation and production and presentation where we can. As I've already said, we need to do some work on our front ends and to increase accessibility, to make sure it's accessible to all users. And the final thing we want to do is combine evidence with the information. So at the moment, this is data presentation and analysis, but we want to try and integrate that with evidence of what works to improve health or improve those indicators of health. And that was it. I hope I haven't overrun. I'll just put some web links up there for those of you that are interested in, and my email address.
Thank you very much, Justine. No, that was perfect in time, and thank you for this very informative and interesting insight in Public Health England's work and your approach to non-communicable disease surveillance in particular. I would now like to open the floor for questions. And well, I could directly start with one from my side. Looking at your fingertips platform, I was wondering if you do evaluate the use of the information, and if so, which groups do access this platform most often?
We do. We do look at who uses it, so where the users come from and which aspects of it that they use most, so which indicators they use and which functionality they use. I don't have all of that information to hand, but primarily our main user is are people within local authorities. Definitely, they are primary users because this is the main source of data for them on the health of their population at local authority level. So they are our main users, yeah.
And you said that the information is not intended to to be used as performance indicators to compare different regions. But how do you prevent, for example, the media to use it for this purpose? This is something that pops up in Germany when it comes to the question of comparing data also with other European countries and comparisons within the country.
Yeah, so people do that, but I think so most of our indicators are presented, so they compare the local authority to England. So we present it that way. We don't produce rankings. So we do get asked for rankings quite a lot. We try to avoid that where possible. And I guess we try to provide appropriate caveats. One of the things I didn't show is all the metadata that we produce with the indicators, which helps to guide people around the caveats in interpretation and what they should use the indicators for. So that we try and mitigate the risk of that, I suppose, but we can't eliminate. It's open source, so people can use it how they want to use it. Yeah.
Okay, so there is no limitation in the use also from the international side to use that for European health comparison purposes, for example.
No.
And do you also intend to have a regular exchange with the user groups?
So we do that. That's mostly done by our local knowledge and intelligence service. They have various means of communicating with their users. So they have user panels, they have focus groups, they have one-to-one conversations. So there is a lot of that goes on, and they collect a lot of feedback for us as well through those processes. So it's a kind of cycle in that they disseminate the information and then they bring back queries, and hopefully we act on those queries and we make improvements based on those queries and then feed it back. So yeah, that's what we do. Should I stop sharing this screen?
Yeah, that would be very nice. So
okay. Yeah,
larger picture. And you can also see the next question in the chat, which is from our Department for Non-Communicable Diseases and Health Monitoring regarding the data lake. Does it include the data on individual level from different data sources, and is it in an anonymized form?
So it does include data at an individual level from the different data sources. We have role-based access. So for some of those data sources, we do have individual identifiers, but there's other steps that you need to go through if you need to access those, and they're not available to everyone. So there's a kind of, they're separated from the rest of the data, if you like. So they're only used for specific purposes with the appropriate approval. But the majority of it is anonymized for most users, yeah.
Yeah, that's one of the main issues here in Germany, also to connect different databases and data sources to make IDs and linkage between the different data sources, of course. Well, I've learned from my colleagues that you will have the working meeting directly after this talk.
Yes.
And I would very much like to thank you very much for your time and
Thank
your
you.
presentation. And well, I'm just looking one more time in the different sources for questions, but I'm sure that they will come up afterwards in the working session with our colleagues from Department 2. So thank you again, Justine.
Thank you.
And so we can close the meeting, and looking forward to seeing you one time here in Berlin in a physical interaction with our team here. Thank you.
Thank you.